Dr. James Locke is with us this evening, and he's psychiatric director of our comprehensive eating disorders program here at Lucile Packard Children's Hospital. He's a professor in the Stanford Department of Psychiatry and Behavioral Sciences and Pediatrics. Dr. Locke is also a board-certified child and adolescent psychiatrist specializing in the treatment of children and adolescents with eating disorders. He's nationally and internationally recognized as an expert on the psychiatric treatment, and he's written a number of articles as well as 6 books on the subject: Treatment Manual for Anorexia Nervosa, a Family-Based Approach, Help Your Teenager Beat an Eating Disorder, and Treating Bulimia in Adolescents, a Family-Based Approach. So that will be Dr. James Locke who will be speaking.
Thank you all for being here. It's great to see so many people. I'm going to try and talk to you about treatment for eating disorders in a very brief way and provide a little overview for you. These are my disclosures. I like to let people know that the NIH has supported my work and the Hilda and Preston Davis Foundation as well. So what treatments are commonly offered? This is kind of important to see what's offered versus what we know about. So let's start with what's offered. Typically, for anorexia nervosa, psychiatric hospitalization, usually fairly long-term hospitalizations, are offered. Day treatment programs in day hospitals are offered. Residential treatment programs are offered. Usually these are 1 to 2 months, sometimes longer. Individual therapy, sometimes cognitive behavioral therapy, that's what CBT is, and sometimes more psychodynamic developmental therapy, looking at issues around autonomy and self-development. Various forms of family therapy have been suggested to be useful. And then a range of medications are sometimes prescribed. Antipsychotic medications, so-called atypical or novel antipsychotic medications, and antidepressants have all been suggested to be useful. With bulimia, individual therapy has been the main kind of intervention typically used. Cognitive behavioral therapy, interpersonal psychotherapy, something called dialectical behavioral therapy, and something called supportive psychotherapy. Family therapy has also been suggested to be useful for bulimia nervosa. Medications including antidepressants and certain mood stabilizers, and then day programs and residential treatments, as well as sometimes hospitalization. All right, so if you're a parent or a person trying to decide what to do, and you're offered this menu of things, how do you proceed to make decisions about what you will actually try? It's not easy to figure out what you might want to do. Given that long list, you may have ideas. You may talk to a friend. You may talk to someone whose child was treated in one place or another and get an idea. But as scientists, we actually are trying to figure out what treatments actually do work. And it's a little bit daunting to see what the realities are versus what that menu was. This is a slide of the complete published literature on the treatment of anorexia and bulimia in adolescents. Some people are laughing. It makes me want to cry because, it's a very sad slide. The numbers are small, and these are outpatient treatments, psychotherapy treatments. And this is a disorder which Dr. Goldman referred to as correctly and as being described by Morton in 1600s. And we have so little information. So let's just talk about what there is on this slide. At the Maudsley Hospital, Gerald Russell and colleagues published a study in 1987, which was the first study to demonstrate that a treatment was better than another treatment for anorexia nervosa. And that was a form of family therapy that was for adolescents who had been ill for less than 3 years. 21 subjects were in that particular piece of the study. They were about 15 years old. But they did really well. 90% of them were weight restored above the threshold for the criteria for anorexia nervosa at the end of treatment, and continued to be so at follow-up. Arthur Robin, a U.S. researcher from Detroit, did a similar study comparing family therapy to the kind of individual therapy I learned as a resident at UCLA, which was a really developmentally tailored therapy, which the basic idea of which was adolescents with anorexia nervosa feel out of control about their lives, and the stresses and strains of trying to develop their autonomy and take on the challenges of adolescence was overwhelming to them, and they turned to dieting as a strategy to manage that. So he compared a form of that therapy to the family therapy that Russell had shown to be useful in 1987. And family therapy was superior to that form of individual therapy in terms of weight restoration and menstrual return. It was all young women that were in that study. And what was interesting about that, though, is there were no differences in the psychological changes in the patient groups, meaning that family therapy, which really didn't focus so much on the individual psychological state of the adolescent, did just as well as a therapy that was really focused on those things. Small study, 37 subjects. Mean age was about 14 years. Simon Gower's, actually this is a mistake on this slide. I don't know why that happened, but it's actually 165 were in this study. So it's the largest study ever done in anorexia nervosa. Compared treatment as usual, this was in the UK, treatment as usual was what was provided at their community mental health center. And they have the National Health Service, so it was sort of a standard product. Compared to cognitive behavioral therapy, compared to about a 16-week course of inpatient treatment with expertise in totally multimodal inpatient treatment for anorexia nervosa. There were 165 kids in that study. Their ages were about 14. And you'll see here that nobody did particularly well. 18% were recovered that were in hospital, CBT 22, and treatment as usual 31. There were no differences in those numbers statistically. For bulimia, there have been two studies. Bulimia was described later, 1979, as so-called an ominous variant of anorexia nervosa by Gerald Russell. And a study out of the Maudsley Hospital by Ulrike Schmidt and her group compared family therapy of the type that they had used with the first anorexic group to a guided self-help form of CBT, meaning that they had a cognitive behavioral therapy which worked on the cognitions and behaviors, but most of it was done by the patient using a booklet and a program as opposed to having a therapist work with them. There were 85 kids in that study. The mean age was 16.1. And there were no differences between family treatment and CBT at the end of that study. The rates of 36% being abstinent from binging and purging and 42% are pretty comparable to what we would expect to get from CBT, which is the treatment of most evidence for adults with bulimia. Daniel LaGrange, one of my collaborators at the University of Chicago, did a study of 80 adolescents with a comparing family treatment to a supportive individual therapy, and found that family therapy at the end of treatment and at follow-up was superior to individual therapy. So what I put on here now is a summary with little sort of grades. Some of you might have had grades at one point or another. 3 pluses is a good grade. 2 pluses is an okay